Good evening, friends. Welcome to the Tuesday evening critical care sessions from Yashoda Group of Hospitals and Department of Critical Care Medicine and other super specialty departments, particularly today, Department of Neurosciences. We try to bring topics of interest to all of you. Today, I happen to actually accompany one of my colleague who actually was listening these sessions on a drive, was enjoying and complimenting me for all these sessions. These sessions have been happening for almost last 4 years or so, bringing live discussions among many of our specialists and all. Today, it happens to us that in the last couple of weeks or so, we have seen a series of cases which presented with acute altered mentation with encephalopathy, initially as an encephalitis, with some of them had a seizure-like activities to present with as a new onset seizures, and further evaluation could not find any infective etiology, no much of cell series, and the MRI was not of much help. And these patients, some of them had found to have no antibodies in their CSF. We label them clinically as a seronegative or antibody negative autoimmune encephalitis. So that brought us to this idea that many of us, we keep a clinical suspicion of autoimmune encephalitis in any age group, more so in younger age group, with a subacute presentation, with more of a movement disorder, psychiatric symptoms, and the workup of regular infective or imaging seems to be normal or negative. So these were the clinical areas which I always used to give us a clue. But today we wanted to bring those series of cases, and also with that series of cases will be brought by Dr. Madhav. Dr. Madhav Reddy is a senior consultant in the Department of Critical Care Medicine in Yashoda Hospital, High-Tech City. He did his FNB and post-graduation initially from Yashoda, then followed by his FNB in Medanta, and happened to be with us for the last 2 or 3 years. So, and he carries a rich experience in the critical care fraternity. So he will bring us those series of cases. And to actually give our expert opinion, we have a combination of 2 experts. The first expert is the specialty related, Dr. Subaya Chaudhary, a senior neurophysician who actually keeps a lot of curiosity. I was also amazed by his curiosity to actually investigate, evaluate, and always try to find undiagnosed cases to a conclusion with a very open mind. I always like that openness to keep the cases diagnosis. Subaya sir, thank you for accepting our invitation and being here. It's a pleasure to host you, sir.
Thank you.
So we have Dr. Urvi. Urvi is a good friend of mine. Can I have Dr. Urvi Sukla on board? Dr. Urvi is there? Okay, I'll just connect her. So Dr. Urvi will be the other panelist who is an intensivist. I happen to see her in multiple forums discussing about autoimmune encephalitis in many of her discussions. And we have Dr. Durgesh Satalkar also. Dr. Durgesh Satalkar is our expert neurointensivist, exclusively working maybe more than half a decade of time in neurointensive care. And I happen to see his series of autoimmune encephalitis presentation in our previous webinars also. With this, I request Dr. Madhav to start the session. In the meanwhile, I will invite Dr. Urvi also. Over to you, Madhav.
Thanks for the introduction, sir. I'm going to, good evening, everyone, first of all. I'm Dr. Madhav Reddy, consultant critical care in Yashoda High-Tech City. Now I'm going to present a series of cases which were successfully treated with a very different presentations, very, very vague initial diagnostic evaluations, brought to a successful conclusion and very good outcome. Happens to be in the last 2 weeks. My first case is a 49-year-old male who presented with altered sensorium, irrelevant speech, and aggressive behavior initially. Gradually, the speech was reduced to incomprehensible sounds, and within the next day, patient became drowsy and not responding to speech, not able to take feed orally, and had an episode of seizure-like activity at home that lasted for 1 minute, and he did not regain his consciousness after that. This any significant past history that includes diabetes mellitus, hypertension, and hypothyroidism. Patient is a known case of CKD. He is on maintenance hemodialysis, having thrice a week. The last dialysis was done just 2 days earlier, and he was due for the dialysis on the day of admission that he has presented with this altered sensorium and unresponsive state with an episode of seizure-like activity. The history also include an old ischemic stroke for which he is taking aspirin on a regular basis with no residual deficits. During his presentation in the emergency, the patient was drowsy and not arousable, opening his eyes and moving limbs to deep painful stimulus and making incomprehensible sounds and gurgling noise from throat. The GCS observed in the emergency was E2, V2, M4, and the neck stiffness was present. Pooling of oral secretions was present, but intubation was deferred in view of family's apprehension regarding mechanical ventilatory supports. Patient was shifted to the ICU with initiation of initial empirical antibiotics for meningitis and also started on anti-epileptic medications, levetiracetam as a loading followed by 500 mg BD. After receiving in the ICU, patient was intubated for airway protection after convincing the family for mechanical ventilation, and immediately went ahead with an MRI brain to rule out any acute stroke. The focal area of gliosis was there with mild volume loss in the MRI, involving the right superior frontal gyrus and chronic infracrelated sequelae. EEG was done on the same night, suggestive of generalized synchronized periodic shock wave activity 2.5 to 3 hertz per second, lasting more than 10 minutes and suggestive of non-convulsive status epilepticus. Lacosamide loading dose was given and started on midazolam infusion with a continuous EEG monitoring to achieve suppression of seizure activity. CSF analysis was also performed to rule out any infective pathology. CSF analysis revealed a WBC of 2 cells with polymorphonucleosides of 35% and lymphocytes of 65%. Sugars are at 72, whereas the base 11 sugars are 110. The protein were 90, little bit elevated, and the chlorides are also elevated at 126 milliequivalent per liter. ADA came to be 2.91, which was on the lower side of the normal range. PCR meningitis panel were also sent, which came negative. The gram stain suggestive of no microorganisms and gene expert mycobacterial tuberculosis was not detected for any PCR. Continuous EEG was provided at the bedside, suggestive of alpha theta altering patterns, suggestive of cycling of altering patterns of encephalopathy with intermittent triphasic discharges and with anterior to posterior elegy. Serial EEG also showed no further epileptiformic discharges, and midazolam infusion was gradually tapered down at around 1 mg every 12 hourly, gradually from the initial 6 mg per hour, and then discontinued. MRI brain epilepsy protocol was performed, and it is suggestive of suspected meningitis, but again, the CSF was repeated in view of high suspicion. We thought we missed it on the first time. Again, the second time also, it did not reveal much data. So in view of persistently elevated proteins, we also suspected it's an autoimmune encephalitis and went ahead with a PET scan whole body. Autoimmune encephalitis panel was also thought about at that same time, but could not descend because of the cost constraint for this particular patient. But with the management of underlying seizures, patient gradually became awake, aware, conscious, oriented, then gradually patient was extubated and discharged on the later date. Then PET scan report was suggestive of autoimmune encephalitis, but patient was treated for seizure disorder here. Gradually with the management of the seizures, patient became very well. This is the patient's CSF panel, and here is the PET scan report for this patient, PET scans. And this is the PET scan report, which is feature favoring autoimmune encephalitis, and we correlated clinically and went ahead with the diagnosis. I'm presenting the second case here. The second case is 81-year-old male with a background history of diabetic hypertension, bronchial asthma, and dyslipidemia, underlying coronary artery disease for which he was medically being managed with ecospirin. And patient has an history of hallucinations, neuropsychiatric disorder for the past 10 years, and decreased activity and social interactions in the last 2 to 3 months, and increased forgetfulness in the last 1 month. Patient was in low spirits for the past 20 days and having decreased sensorium for the past 1 week. Evaluated outside for encephalopathy. Initial workup was negative, ammonia was negative, outside CT MRI came negative, and they also sent paraneoplastic panel, and the paraneoplastic panel was awaited by the time he arrived to our hospital in an intubated state for airway protection. This patient had underwent MRI and CSF analysis immediately. CSF analysis showing normal steady with bio5 panel negative, and anti-TPO antibodies came negative, and autoimmune encephalitis, a paraneoplastic panel was again sent from our hospital, was awaited at that time. The CSF analysis for HSV 1 and 2 PCR came negative, followed by the report of MRI suggestive of diffuse cerebral atrophy with small vessel ischemia, no abnormal post-contrast enhancement, and ASL demonstrates symmetrical perfusion with no focal areas of abnormal hyper or hypoperfusion. EEG recorded at the bedside suggestive of abnormal EEG recording, suggestive of grade 2 encephalopathy with GPDs noted to correlate clinically regarding the patient condition. This shifted us to patient gradually became GCS further dropped, got intubated in the ER by the time he presented to us with the seizures, and we assumed it is autoimmune encephalitis and initially started with pulse steroid once the procalcitonin was negative. Paraneoplastic panel that was awaited revealed recovery in antibodies. So we went ahead with PET scan whole body, looking for any tumor-related paraneoplastic syndrome. Also look for autoimmune encephalitis. At the same time, we started him on 3 doses of pulse steroid, and gradually patients started responding. We have completely given the 5 days of IVIG therapy for this patient. PET scan suggestive of diffuse moderate hypermetabolism involving frontal cortex of the brain, moderate hypermetabolism involving bilateral basal ganglia, thalamus, brainstem, and medial temporal cortex of the brain, and the possibility of autoimmune encephalitis was considered immediately and went ahead with both pulse steroid and IVIG. And these were the PET scan images of this patient. Patient also had an elevated tropi that was sent from the hospital, and sequential tropi was elevated, and we considered medical conservative management for the patient because patient is in a very poor neurological state. Patient also had increased number of pus cells, was treated with IV antibiotics for urosepsis. GCS became slowly better and started with eye tracking, and repeated CSF also revealed no much information. Autonomic dysfunction was there with labile hemodynamics. Autoimmune panel came negative for this patient, and gradually the patient became conscious and following command. So because patient could not be extubated from mechanical ventilation, patient was tracheostomized to BiPAP support, and patient is planned to send for rehabilitation care. This is the patient's CSF analysis report with a WBC count of 7 with polymorphs of 10 and lymphocytes of 90%. Whereas CSF biochemical analysis revealed marginally elevated proteins with no significant drop in the sugars. Now I'm presenting a series of the cases as third case. Here a 60-year-old male presented with fever, chills, and generalized weakness for the past 5 days with tremors, unable to walk, and had an episode of fall 2 days ago. Sudden onset of involuntary movements and tongue bite at around 11 a.m. While on his way to the hospital from another hospital for further care. After that, he did not regain his consciousness. So on presentation to the emergency, patient GCS observed was E2, V2, M5. Patient was having fever and hemodynamically being very stable. Patient was intubated in the emergency in view of airway protection. And initial suspicion was because patient was having fever and presented with altered sensorium via suspected viral meningoencephalitis. Anti-epileptic measures was initiated immediately, and empirically patient started on ceftriaxone and acyclovir. MRI epilepsy protocol was performed on the same night, showing asymmetric hypoperfusion in the right anterior temporal lobe and probably related to periictal status. Routine blood investigations were unremarkable. We have sent the CSF analysis suspecting meningitis, which showed elevated sugars and proteins not in line with meningitis. The entire meningitis panel came negative. By this time, we have completed first 24 hours. So we went ahead with nerve conduction studies, which showed motor and axonal neuropathy pattern. And myositis panel was also sent, which was negative. He had seizures-like activity with uprolling of eyes on the same day, which subsided with midazolam. So he had fever spikes, temperature maximum going up to 105 degrees Fahrenheit. Blood and urine culture was sterile with further follow-up, and inflammatory biomarker, CRP, procalcitonin, all were negative. So it is suggestive of non-infective pathology. This is a biofile of CSF, which came negative. And the CSF autoimmune panel was sent suspecting autoimmune encephalitis, which came negative for this patient. A repeat EEG was performed after 4 days, suggestive of non-convulsive status epilepticus. And for this patient, we have increased the anti-epileptic dosage. Autoimmune encephalitis was suspected at this point. We went ahead with the PET scan, considering there is no other alternative diagnosis available. This PET scan showed asymmetrical temporal uptake and with suppressed bilateral basal ganglia signals. A diagnosis of seronegative autoimmune encephalitis was made. He was initiated on pulse steroid therapy with methylprednisolone after ruling out any infective pathology. Lacosamide was added in view of intermittent electrical activity. IVIG was initiated, and a repeat EEG for 6 hours was performed with no seizure activity recorded. These are his PET scans. So this patient also we try to trace the autoimmune encephalitis panel, which is completely negative. So on day 4 of pulsing steroid, on day 2 of IVIG, the patient's GCS started improving and the patient became conscious oriented. Patient was extubated and there was a delayed response to the speech, but gradually the patient continues to improve. Involuntary movements and oromandibular dyskinesia was present, for which we started him on sodium valproate. Repeat EEG, again not suggestive of any seizure activity. He was further mobilized out of the bed and able to mobilize with support, and gradually patient shifted to rehabilitative care. Thank you.
Thank you. Thank you, Madhav. Can we make it a full screen? Thank you, Madhav, for you can stop sharing, Madhav.
Yes.
Yeah, so thank you for that presentation. I think Madhav was pitched in for on an acute call, like an acute emergency, because Ravi has been occupied with 2 ECMOs initiation yesterday. Sometimes we do see these nightmares when you have a presentation, when you have a something to go or something to call, you will have more emergencies on that day. And yesterday was not a different day. He initiated 1 ECMO in-house and he flew to another place, initiated another ECMO, and they came in the afternoon here from Raichur. Luckily, both of the patients were doing good. So Madhav has taken the role of actually presenting both the cases in a quick way. To bring the discussion, actually, if you look at these 3 cases, any of us in the intensive care unit will take those cases as a possibly a viral encephalitis or some form of infective etiology. And when our infective workup turns to be negative and our MRI becomes normal, MRI comes as a normal, then we start thinking about, are we missing something else? And in the process, this autoimmune encephalitis diagnosis is more often be a part of it. But today's discussion is when we send a autoimmune encephalitis panel, we have a very few set of antibodies which have been tested in that. We can see very few antibodies, 5 or 6 has been tested. Either you look at them in our list also in that pattern. So those 5 or 6 turns to be negative. So we say antibody negative, but we still call them as an autoimmune encephalitis. So my first question uh, to Dr. Subhaya Chaudhary sir is, do we need a autoimmune antibody to be positive to call a patient's diagnosis as an autoimmune encephalitis? Is it a mandatory to have an antibody being positive?
So thank you, Venkat, for making me a part of this so that I can also learn from so many things from all of you. That's a very important, interesting question. And definitely, clinical suspicion is the most important thing. As you said, viral encephalitis is the most common differential diagnosis. And the third thing is clinical suspicion should be high and it need not be always seropositive. If you take percentage wise seropositive and seronegative, almost you get 50% of the case as per the literature. But most of the times, we still see more of seronegative rather than seropositive. Probably what is all based on Western literature, the antibody response may be 50% there. Maybe for our pattern, it may be little different because of so many viral diseases, pre-exposure viral diseases. I think as the day comes and more antibodies coming, this seronegative will become seropositive, or maybe T cell immunity based autoimmunity need not be positive, seropositive. That's the important thing what we have to think of.
The interesting message is we don't need to have mandatory criteria of antibodies being positive. The reason
Yes.
can be vary. As you said, the literature supports 40 to 50% autoimmune encephalitis are seronegative. The reasons again, whether we are not able to detect the antibody or the antibodies are negative because of the, as you said, the different mechanisms to detect them. So both can be the reasons. Clinical syndrome, exclusion of mimics of autoimmune encephalitis remains the first line of diagnostic criteria rather than only antibody mediated. Ma'am, coming back to you, when actually we put across somebody saying antibody negative autoimmune encephalitis, okay, this is again a clinical acumen, but this comes with a set of doubts in our mind. Are we dealing with a viral encephalitis with your viral panel being negative, and all that also comes into your mind. So, do you suggest some criteria like GRAIS 2016 criteria or something, or any clinical parameters or scoring systems you use, Dr. Urvi?
Yeah, so very rightly mentioned that there is always going to be a doubt in our minds that we may be missing a viral infection, and creating a situation where we have immunosuppressed the patient and the infection flares up. So there is a grouse criteria that was proposed. It was proposed in 2016. However, it is not very specific for a particular type of autoimmune encephalitis. But what it mentions is that the criteria have to be, all three of them have to be present, and only then we can say that there is a possibility of autoimmune encephalitis. The first one is it has to be a subacute onset. So anything that comes with a very acute onset, less than a week, less likely to be autoimmune. But subacute, minimum of more than a week and up to 3 months is what is mentioned there. There should be some degree of altered mental status, some memory loss, along with some other psychiatric symptoms in a patient who was not known to have pre-existing psychiatric problem. I think one of the patients' cases that were presented today, there was a history of a psychiatric ailment. So you will have to be, anybody who is actually trying to diagnose autoimmune encephalitis will have to keep this in mind. And then at least one of the following findings, there should be a new focal CNS finding. There should be seizures which are not explained by a previously known seizure activity. CSF, when we do, we should have at least 5 cells, if not more, and MRI features to be suggestive of encephalitis. So obviously all this comes with the caveat that you have reasonably excluded all other possibilities of why this patient is in this situation.
So you need one of these criteria plus a subacute presentation.
Presentation.
So this is again a clinical criteria.
Yeah.
Dr. Subhaya Chaudhary, you are there in many of your situations. Many you treat with only as a viral with acyclovir and weight, and then few of the cases you say it looks like more of a autoimmune encephalitis. How do you take a call on that? When it comes to a clinical, it becomes a subjective. All these parameters become a subjective. We are away from your antibodies and we know the limitations of antibody detection because of many reasons. So which are the areas where you say, okay, this case looks more to me an autoimmune encephalitis, or when do you come to that conclusion in your clinical practice?
Yeah. Once again, before considering autoimmune, the most important thing is we should exclude, especially in seronegative, we should exclude other diseases like metabolic or viral or some other things. One. Second thing, if a patient has usually most of the herpes simplex herpes encephalitis cases, they're acute in onset usually. And most of the viral encephalitis, if you do CSF, cells will be more and protein may be high. But one more thing is, if you see the MRI, usually you have asymmetry involvement of the medial temporal lobes in viral encephalitis. And whereas in autoimmune encephalitis, MRI, if it is involved, usually it is bilaterally symmetrical. Suppose you have a doubt, there is no wrong in starting acyclovir and see for 2 days, and we are still clinically suspicious is high. There is no wrong in treating with IV methylprednisolone.
How do you?
Actually, we have a in-hospital case who is acyclovir positive, who is herpes simplex case, herpes encephalitis case positive, and it later turned out to be autoimmune encephalitis, because what they say is herpes
Yeah.
encephalitis cases, they can
Yes.
become autoimmune encephalitis. We have a clear-cut case demonstration in our own hospital during the course. It has turned out to be autoimmune encephalitis.
So you mean to say that this autoimmune trigger can be most of the times can be an infective origin, can be some tumor origin, and that spectrum remains to be there.
Yes.
Where sometimes we may have a etiology, sometimes we may not have
You
etiology.
may not have it.
Dr. Urvi, question back to you. Many of the times you said there can be some pleocytosis, there can be some encephalitis features, which are one of those uh, clinical criteria mentioned. But does a normal MRI, does a normal CSF rules out a possibility of a autoimmune encephalitis?
No, I think in almost 40 to 50% of the patients, MRI may not have features. That is why I think Dr. Suresh said that if the MRI is positive, then the findings are likely to be symmetrical. So I think that is a very important point there, that big if carries a lot of meaning. And even early on, the CSF may be completely normal in up to 30% of the patients. So very difficult to say if both are normal, whether we categorically can rule out autoimmune encephalitis is a question mark. So we still have to rely on the clinical features.
Dr. Subbe, Dr. Madhav presented a couple of cases where we talked about limbic hyperintensity, basal ganglia's involvement, maybe symmetrical cortical involvement. What is that typical limbic related encephalitis?
That's the medial temporal lobe involvement. Usually basal ganglia, they get involved more in autoimmune encephalitis. That's the most important thing.
What is the percentage of times you pick up that as a part of your
MRI usually we pick up only in 50% of the cases. PET scan 70 to 90% of the cases. If the clinical suspicion is high, you can repeat after 2 weeks where it can be positive.
Okay. What is the role of oligoclonal glands and IgG index, which we are talking about? Some of those also mention about them, even though they are more specific for multiple sclerosis. What is the role of picking up a
Yeah.
oligoclonal
See,
gland?
the simple meaning is oligoclonal bands means the antibodies are, the brain is now used to, it is starting its own factory to produce antibodies. I can put you like this. So it is establishing its own factory to producing these IgG antibodies. See, in case of these oligoclonal bands, sometimes the peripheral IgG antibodies which are produced, they can cross into the blood-brain barrier. So sometimes you may get confused whether these IgG antibodies are produced in the periphery or the brain is itself is producing it. So you calculate this IgG index. When the IgG index is more, that means the CSF is producing more. It is not only the leak from the periphery. If the seronegative, if it is seronegative and if it is only oligoclonal bands positive in the CSF, that is more indication that it is producing from the CNS itself. Suppose if you are presenting, if they are present in both CSF and serum, and if the ratio is more, that is IgG index is more, it indicates that the CSF antibodies are more and it is producing itself, by the brain itself.
Dr. Durgesh, you have come across a lot of cases and very typical features. You can adjust your camera. We are only able to see you 50% of you. Yeah. So we have seen cases where there were mentioned about a relatively younger individuals, maybe within teenage of 14 to 24. You had a couple of cases with a very choreotic, athertotic movements and with some of those psychiatric symptoms, presentations. Very classic about autoimmune encephalitis. What is your comment on that? We don't see those kind of patterns in viral encephalitis.
Yeah, sir. Good evening for giving me as a panelist role, and it is a good platform to learn from all the senior persons as well as from Venkat sir. So, as the discussion is ongoing, so basically, as intensivist, we come across whenever this type of patient may present in a status epilepticus. When this patient goes in super refractory and refractory status epilepticus, so probably with a discussion with our neurology colleague, so when we come across or we think that we might be dealing a case of autoimmune encephalitis. Probably it is not responding to any other our conventional anti-epileptic medications. So in that situation, we may consider probably we are dealing with any autoimmune encephalitis. Probably this NORS, if you see NORS, almost 50% are cryptogenic and 50% are autoimmune. On that 50% autoimmune also, probably we may don't have our, this is our suspicion, we may not have any antibody positive. So probably in that situation, we consider to be starting an early immunotherapy. So in the form of steroid or pulsing steroid kind of.
So you had brought another point. See, you're talking about a new onset refractory status epilepticus. If we do not find any etiological factors either in the form of parenchyma in the parenchyma of the brain or in the infective, they turn to be a possibility of autoimmune encephalitis. But Subhay sir, my question was related to presentation, psychiatric symptoms, movement disorders like presentation, younger individuals. Is there classical of autoimmune encephalitis, or do we come across that as a common
No,
pattern?
it need not be because they need not always. Most of our patients, they don't have that type of. Well, I think only one patient or post-dengue we had a movement disorder. So it doesn't mean that always we should have movement disorders presentation. Definitely.
So the second question is, you said the two contexts. So one is you said post-infective or post-neoplastic, paraneoplastic phenomenon as an autoimmune encephalitis. So does PET is done whole body to actually exclude a possibility of a paraneoplastic phenomenon, or the PET has a different role to play?
Honestly, if the cost is not a factor, I will do all the patients whole body PET scan. But if cost is a limitation factor, at least I will do brain, and if it is positive, I will do the rest of the body. The reason is, especially young women, if they are having autoimmune encephalitis, most important thing is we have to rule out teratoma. That's the most important. And sometimes LG1 or any GABA receptor antibodies are present. So sometimes you have to exclude small cell carcinoma and those things. So definitely we have to exclude paraneoplastic also can produce, especially in seronegative, because that is usually paraneoplastic most of the time, even if it is seronegative T cell mediated immunity. So we may not get antibodies positive. So that was the reason we preferably do PET scan. I hope I answered your question, right?
Yes, yes, sir. So there are some questions related to that. Some patients. So is it is seronegative autoimmune encephalitis? Please give us more lights on this. Actually, a patient who actually had a NORSI, that is new onset refractory status epilepticus, 35 years, and then had a visible seizures continuously almost for 4 days. Also probably had a the autoimmune encephalitis panel negative. It was not mentioned. So is this a possibility of autoimmune encephalitis? Probably that's what I think Dr. Durgesh was trying to point out. There is a possibility that 50% of the times the new onset status epilepticus or refractory status epilepticus can be from this autoimmune origin, provided we ruled out other mimics in that category. How do you differentiate between antibody negative autoimmune encephalitis from viral encephalitis with negative PCR, or we do a CJD disease? So Besar, I think you answered that, but do you want to again respond to this?
Which one? What?
Viral encephalitis,
Yeah,
CZ.
it was answered. So I'll repeat again. If the CSF count is more than 50 cells, more likely it may land up in viral encephalitis. And more the higher the protein, it goes more in favor of viral encephalitis. And also if any preclinical symptoms or acute symptoms like fever or acute demarcation is there, it goes more in favor of viral infections. And once again, if HSC-PCR is negative, it doesn't mean that it may be negative. We have to repeat after 48 hours also if clinical suspicion is high. So if, as I already told, if MRI is positive, it will be symmetrically positive usually in autoimmune, whereas asymmetrically positive. And important thing is you have a hemorrhagic necrosis will be there in case of viral encephalitis. And also you will have RBCs in the CSF that gives a clue to the herpes simplex encephalitis. If RBCs are present in the CSF, you have to be very careful in commenting about autoimmune, unless it is traumatic.
Dr. Urvi, the antibodies which are there in Madhav's panel are very limited. I can see 5 or 6 which are commonly used,
Yeah.
are mentioned. So, but when I see up to date or I screen other literature, there is a huge amount of antibodies. I think the list has been increasing every day.
Yeah.
We annually, whenever I cross verify, the number goes up. What is your panel? I'm sure you must be also doing or following some panel.
Yes. No, we have the same 5 that you showed us. And if we have to do an extended panel right now, I think Amrita Institute has an extended panel for autoimmune encephalitis. So, at 2 such incidences, we have sent our samples to Amrita. It takes, obviously, it's a very expensive affair plus transport of biological samples, but there are some intermediary labs that do it from Pune at least.
Okay.
But yes, there are a lot of antibodies that we are not able to detect, or we don't have the reagents or the kits to actually detect those antibodies.
So, sir, any other extended antibody testing done in NIMANS or some other neurocenters in this?
No, I think the list goes on. Actually, there are so many autoimmune antibodies, it's really difficult to track. Let me tell you honestly. So if you take nowadays nodal paranodal antibodies also have come for peripheral neuropathies. GM1 ganglioside antibodies have come. So many things are coming up. And I think whatever we are doing currently, our ICU with seizures, I think till we get a further updation, these antibodies, I feel definitely that is not a I mean, I think that should be sufficient at least time being, whatever we are having it. I think we should not get panic that it has come negative. We have to apply all our other clinical skills, exclude other things, and I think we have to treat that.
Okay.
Unless it is a antibody specific treatment comes. Most of the times, if the antibody specific treatment is not there, of course, I agree. If there is a seropositive is there, you give us one type of treatment. Seronegative, you can have other protocol. But as long as if the antibody is positive, I think we may not, I mean, there's no much worry actually. That's what I feel. We may over treat it, but I think we should not at the same
So
time.
I'll come to that. If you have a patient where your antibody workup is negative, or you treat much before your workup comes back to you. I
That's
think
what we are
wait.
doing now.
We don't wait.
We
The
don't.
question is, by some reason, the patients, this kind of patients has possibly, luckily, many of our patients are doing well, but we also see the other side. So
Yeah.
how medico-legally, ethically you have a stand when your autoantibodies are negative and you level them as a autoimmune encephalitis, Is it is family and you confidence say decision, or it's just a trust on each other? It's a clinical acumen. How do you stand?
I think in India we have that advantage. Tell them honestly. If they want, let them have a thought. Now every alternate house has a doctor. They can always discuss. And I put across them. This is what I am suspecting. If it is my mother or father, I am going to do the same thing. That's what I put across
How
them.
do you face that?
See, I think probably I think most of them they accept. Let me tell
I
you.
wanted Dr. Urvi's opinion on that. How they.
So we have had a couple of patients like this, both elderly gentlemen, 2 to 3 weeks history of memory loss, irrelevant speech, and some psychiatric disorder. Initially being treated on antipsychotics, not getting better, so came to us, had to get admitted to ICU, and from then on they just started deteriorating. So we had to the GCS dropped, we had to intubate the patient. We did an LP. Our panel came negative. We sent one sample to Amrita, that also came negative. Then it became very difficult for us to justify IVIG, the pulse steroid, and rituximab, which was planned for later on. But it was a very difficult situation for us to explain, because, in spite of our neurologist, the ICU team, and the general physician who was, part of the MDT, talking to the family, they were not willing to accept that what we had done was right. So it can get very, very nasty, is has been my experience.
So coming back to an interesting point, elderly. I look at Madhav's all the three series and I see most
Yeah.
of these cases are elderly.
Yes.
Whereas most of our autoimmune disorders, we look at a younger individuals. Now,
Yes.
the elderly, we consider it is probably out of box. But we always know that autoimmune encephalitis can play a role in extreme age groups also. So
Yes.
what is your experience on that?
uh, is it for me?
Yeah, you can also take, ma'am.
Yeah, so we have seen all range. We have seen young girls, and we have seen the two patients that I mentioned. They were very elderly. One was 82-year-old, the other one was in the 70s. So we have been seeing a diverse age range. So now to kind of say that, oh, it happens only in young individuals, I think would be a wrong statement to make. So
Yes.
age is not specific.
Yeah, Subhay sir, what is your? We are seeing more of elderly age group.
I feel we see more of a probably our clinical suspicion. One. Second thing is most for seronegative patients are elderly patients. Seropositive patients are younger patients. This is only our observation. I am not telling this is the hard and fast rule. I think because you all will be will be working together. You also might have noticed most of our senior elderly patients are seronegative. That's what we can say.
So, when do you initiate treatment? Suppose
Sir,
you,
I have a question from intensive care perspective.
yeah, please.
Uh, these patients have come with ongoing seizure activity, non-convulsive convulsive status epilepticus, some NSSE or status with an ongoing treatment. And how aggressive we need to be in evaluating the patient for autoimmune encephalitis, going for LP, going for PET scan, at the same time controlling the seizures with multiple medications and infusions. When we found when we find the PET scan report, and the immediately the question comes from the family is we why we have waited for
Yeah.
controlling the seizures and medications, and the stability to come. And obviously we also know that early initiation of immunotherapy will result in better outcomes. So how aggressive we should be in going for further evaluation in terms of autoimmune encephalitis in active seizures patients?
Yeah, so I feel that we are always going to stand this test of fire, and but basics remain basics, and fundamental principles have to be followed. So if this patient has a GCS of less than 8, the patient needs to get intubated. Patient needs to get their first dose of lorazepam, followed by the loading doses of your anti-epileptic drugs, followed by doing an EEG, followed by relaxant, adequate sedation before, and a basic CT brain to rule out any big pathology before an LP can be attempted. And that might take a few hours to maybe some more hours, but at least this is what I feel after seeing patients in the ICU, that unless we follow first principles and fundamental basics are done correctly, we stand to lose more than what we stand to gain.
Agreed. So the basics remains to be standard. You rule out the common pathologies first. First things comes first. Basics things comes first. Then probably when all of them are negative and you don't have a clue, then you go to these all possibilities. So, sir, the other discussion is,
Shall I
yeah,
continue
please.
with Madhav's answer? One thing is, Madhav, you mean what you mean? You are putting the question on directly on NARS. If I don't, if I'm, if
Yeah,
I'm,
yeah,
Yes,
yes,
sir. Yeah,
yes.
yes, sir. Yeah.
see, one thing, NARS, it technically means that until unless it is proven otherwise, if the patient, that means the patient is getting first time status. Most of the times you have to take by default, it is like until other proven otherwise, you should take it as an autoimmune.
Agreed.
Yes.
That's the important thing. So
Okay.
even you treat the seizures, they're not coming down, you exclude other things, and you have to go with the treatment. And now one important update I want to tell you is any patient of NORS, if he is going into status, I think rather than IVIG, now the clear thing demarcation is you better go for plasmapheresis.
Flex.
That's important thing. Next is you have a tocilizumab or anakinra. So you can go with the
We'll come to
tocilizumab.
that,
Now
sir.
the indications are very clear and it is coming very nicely now. How they
Yeah,
are
we
because
are evolving.
yes, they are evolving. Tocilizumab
We will
attacks
come to
IL-6.
the treatment part, sir.
Yes.
Coming to the investigation,
Yeah.
I've seen many times in your rounds, you made a point that sometimes PET CT may overread. Don't be very judgmental or conclusive about a PET CT report because sometimes you also believe it can overread things. But most of the PET CTs which Dr. Madhav showed has at least a hint of things that looks like possibly autoimmune encephalitis. Some part of our skin has saved there if that kind of clue comes. But what is your take? Is PET CT gives an additional clue? What is the role of PET CT in diagnosing an autoimmune encephalitis?
Yeah, leave me individually. I'm little obsessed. Let me tell you honestly. PET scan, yeah, it has its own. I mean, see, the PET scan is not doing the mistake. It is our eye which may sometimes it itself may deceive us. So, you take two inter observers. Always no. I mean, most of them they differ in their giving the report. I mean, that I'm giving it very careful. I'm giving that statement. That's the reason I tell them to have a careful. We have to go by the clinical basis along with the PET scan. That's what I mean. That's what always I mean in the
The
rounds.
other component I wanted to just say, we are labeling this as an autoimmune encephalitis. But if you go back to a decade, maybe in early parts of 2010 and 15, we were talking about anti-TPO encephalopathy or Hashimoto's encephalopathy, where we used to evaluate anti-TPO antibodies, and then later on they stopped the term. They said steroid responsive encephalopathy or steroid helping encephalopathy kind of thing. So are we talking something like that? Like anti-TPO was one of those components. Now we are talking where steroids are helping in some of these cases. We don't know whether there is an antibody, there is an autoimmune phenomenon, something like that. So how do you correlate anti-TPO antibodies, Hashimoto's encephalopathy, steroid response encephalopathy with autoimmune encephalitis?
See what some of them they say that if somebody has anti-TPO antibodies positive, their autoimmune component is high. But if you really check, so many patients we see TPO antibodies positive without thyroid. So
Yes.
many patients we see without autoimmune, any other problem, they have only TPO antibodies positive. I think that part we have to read it very carefully. Maybe we have to be, I mean, if TPO antibodies positive with periodic complexes coming, respond, as you said, responding to immunosuppressants, that they used to treat as Hashimoto's encephalopathy previously. Now,
Okay.
in the context of current autoimmune encephalitis, I think the treatment remains the same. I mean, that's what I feel.
So how are we going to approach these cases? The discussion is whenever these cases comes to us, the initial suspicion remains to the most common ones, that is encephalitis or some infective etiology with the same typical presentation. The therapies by standard empiric will remain acyclovir, sometimes cover with enceftriaxone, waiting for a imaging CSF and all. So when do you actually come to a conclusion and start therapy? I have seen many times we don't wait for our autoantibody reports or encephalitis report to come back. The CSF reports will still be pending. Turnaround time may vary between 3 days to 5 days time. So what is that window at which you take a call after you initiated an acyclovir, and what will make you to go to a therapy?
Yeah, if 48 hours to 72 hours, I mean, if we get usually nowadays we are getting HSC PCR very fast. So
Okay.
HSC PCR is
HSC
negative.
PCR is negative.
And MRI, of course, excluding, and CSF excluding, and PET scan, if it is positive showing something like a bilateral changes in the basal ganglia, we take it as an autoimmune.
And
And
how do you approach these therapies? The first line therapy remains the
first line therapy, always if the patient is quite stable, the steroid is the first one because it's a fire extinguisher. It acts very fast. And so we give 5 days of IV methylprednisolone. And if the patient doesn't respond by the end of the steroids, then we go for IVIG. But nowadays, what we do is most of the patients, if we see that the patient is very rapidly progressing, elderly man, having a little bit problem, we always combine both the things so that steroids we give only 3 days because just to extinguish the fire and then let the IVIG takes off. And if IVIG, we wait for IVIG. Luckily, most of our patients, they're responding with IVIG or plasmapheresis. We wait for 2 weeks. If the patient is still not responding, probably we go for rituximab or cyclophosphamide. So it keeps on going on. You can stop wherever you would like to stop.
What is your pattern there? Steroids in a pulsing dose plus IVIG minus IVIG or plasma exchange. I think Dr. Subhash sir has brought another controversy, IVIG versus plasma exchange.
So here, sir, predominantly whenever there is a suspicion we are dealing, first is pulse therapy of methylprednisolone, and followed by I think IVIG, because anyway after 3 days of this we have to start an IVIG. More for what we have seen observed in that cases. So after methylprednisolone, after probably 48 hours, we probably initiate IVIG. So then probably the responses we have got positive, but plasma exchange not very frequent we have tried, but these two combination methylpred and IVIG, first with methylpred then IVIG.
So, Bhair sir, you said that plasma exchange has now been considered as an alternative. My problem will be if I have given IVIG, probably for next 21 days, I will not do a plasma paresis because it will take out all my IVIGs and will waste my 5 lakh rupees. So, you want either plasma exchange versus IVIG, or how do you go about?
If the patient is young, fit enough, I would like to go for my preference is plasmapheresis because I feel it is more of a, pathologically oriented treatment. That's what I feel. So if the patient is elderly man, hemodynamically unstable, I would go for IVIG. So, but once if IVIG is given, maybe as you said, till 3 weeks, I won't do plasmapheresis.
Doctor,
So,
when is the immunomodulator comes there?
Sorry.
you want me to answer?
Urvi madam.
Oh, okay, ma'am. Yes.
So I'll tell you what we are doing, and Sujay sir can tell me if this is right or wrong. So we are doing pulse steroid followed by IVIG, and then 5 cycles, 5 days of IVIG. If they don't start responding, then our neurologists are actually saying immunotherapy on the 8th day or 9th day. So 3 days of steroids plus IVIG, and then depending on clinical response, immunotherapy.
Okay. So what is the choice immunotherapy, Subhash sir? You've been using rituximab or a cyclophosphamide?
No. See, I just want to add madam's this one what she has told. Usually, after the IVIG, unless there is no autonomic instability, patient is doing well. I mean, patient is not that unstable. I think we can wait at least up to 1 to 2 weeks. There's no need of hurry. That's what I feel.
Okay.
One. And second thing is preference of choice is, see, here once again, honestly, if you take rituximab versus cyclophosphamide, if you go through this one, cyclophosphamide is a poor man's rituximab.
Yeah. Yes.
Rituximab is maybe safer one. But the point here is rituximab, though we are giving rituximab, we are not giving cyclophosphamide because it's difficult to tune the patients once again. Oh, they say it's a cancerous drug, anti-cancerous drug like that. And rituximab, usually in seropositive cases, rituximab is more effective because it is going to target the B cell
B cell.
immunity. Whereas cyclophosphamide, it targets both T cell immunity and B cell immunity. So if you have a seronegative, you are more justified in giving cyclophosphamide rather than rituximab. But once again, it doesn't mean that that patient who has seronegative doesn't mean that his antibodies are not there. Probably we haven't identified the
Able
antibodies.
to identify
Still,
where
that antibodies are in the pipeline to be discovered. Second thing is the antibodies may be restricted to the brain tissue itself. They are not coming out. That where when we measure the CSF, it is restricted only there. So that could be the
So
reason.
this brought me another interesting controversy. What are the serum assessments of these antibodies rather than CSF?
No, actually, but double positive is always very important. Except LG1, which is serum is more positive, whereas if you take NMDA receptor antibodies, CSF has more value. Like that, you should take that one. If the patient has both the antibodies positive, it is
Serum levels also are available in India?
yeah. LG1 usually we do only serum rather than CSF. CSF NMDA is more sensitive, more specific.
Okay. And now you came to the newer two therapies which has been evaluated in the form of tocilizumab and anakinra. So what is the role of these two new drugs in current era?
So actually, if you take NORS is new onset refractory status epilepticus where Dr. Durgesh has brought out, and FIRES is in the pediatric age group, or if the patient any age group, if they have a autoimmune encephalitis or seizures, it's a seizures who are refractory new onset. If they have preceding fever, that means it comes under FIRES. Whereas the patient doesn't have fever and it is a chronic, it's a little prolonged course, we take it as a more of a NORS. So here the pathology is you have IL-6, whether you have to target IL-6 or IL-1. In FIRES, you have IL-1 more. In NORS, you have IL-6 more. So that's the reason tocilizumab is the IL-6 inhibitor, whereas anakinra is the IL-1 inhibitor.
Right.
So if the patient has a acute onset, fever, children, rapid onset, you can use anakinra. Or if the patient is having, long standing, especially in the adults. So without any fever cause, refractory status epilepticus, new one, you can go for tocilizumab. That's the way. But it doesn't mean that you should always follow that children will never have NORS and adults will never have FIRES. The common is like that, FIRES in children and NORS in adults.
Any role of intrathecal steroids? One of the questions in the chat box.
Honestly, I don't have an experience. I don't. I think it's more aggressive. I don't know.
Okay, I think there are a lot of questions related to NORSI, which has been a different topic altogether. We've been treating NORSI with antiepileptics and other measures as a refractor, other than add on to this therapy. Dr. Durgesh, any comments or points from you? You want to ask any questions to both the panelists?
So, sir, nowadays what we have seen the couple of cases more of elderly, we have seen younger age group, which is in the especially female 20s and 25. A couple of cases they have started present. Initial same presentation was NORS. So there, what we did a PET scan slightly earlier, rather than delaying it because initial MRI scan, initial lab and all, they are not very contributory. But what we have found that in PET scan there are hyperintensities like in basal ganglia and hippocampal areas. So from there, and there was probable diagnosis is consider an autoimmune encephalitis. Simultaneously we did a lumbar puncture and all, we send a sample for autoimmune panel, but we didn't wait to start immunotherapy, in the sense that steroid we have started. So probably the role of PET scan to exclude is might be earlier rather than we are delaying it. So if nothing comes out, then doing a PET scan. So I think a PET scan might be considered earlier. What is that? Role of it, and what is the opinion of our senior panelists, Dr. Subbaya sir and Urvia madam?
Madam, you want to take on the answer, or you want me to answer?
Sir, as a routine feature, if the what we are doing, I can say, I don't, again, I would like you to validate. Uh, we are seeing if the state, if on EEG, the epilepsy has not settled after 24 to 48 hours of, adequate anti-epileptic treatment, then we put them up for a PET CT, because obviously if we are giving them so many drugs, they are already sedated and intubated. So shifting them for a PET is easy in that sense. So this is what we have been doing. But is it, if does the question mean earlier than 48 hours? Then I'm not sure. I have never done.
I think by the time we do the PET scan, it will be always, most of the times it is 48 hours. I think doing early, and if the PET scan is inconclusive or we don't get an answer, there is no wrong in repeating after 1 to 2 weeks.
Okay.
By the time we settle down the patient, it will take 48 hours, because we are going to treat the patient, treat the seizures. By the time they come to us, they come from the,
Yeah.
especially when we are in the quaternary or tertiary hospital, by the time we come, I think they will take more than that time. So we are
Sure.
justified in doing 2 PET scans.
Any questions from Madhav? Madhav, you wanted to ask anything?
Sir, regarding the autoimmune encephalitis panel itself, the panel generally takes a lot of time, and in the meanwhile, we initiate therapy. So, does our therapy has to be titrated whether the panel will come positive or not? We don't know. So, should there be any difference between the initial management?
No.
So that's what you want me to take the answer?
Yeah,
Yes,
sir.
yes, yes, sir.
Yeah. Suppose if it is seropositive, your life is easy because you can treat with the rituximab.
Confident.
If with the steroids. Suppose if you are treating a seronegative patient, definitely it is a challenging one. One is two things. It is sometimes if the antibody is there, but it is not being detected because we haven't yet discovered, rituximab may work. But suppose if it is T-cell mediated immunity based, our antibody will never come positive and it may not respond to rituximab. There you may have to go for cyclophosphamide. So definitely, if you are more safe if your antibody is positive rather than negative. If it is, and also convincing the patient attendance also is important here, and prognostication. I think your life will be easy if it is positive.
Thank you.
Sir, sir, one last question, sir. Should we consider the even seronegatives are also seropositive, considering these antibodies are yet to be detected? Probably the titers are not there. Is there any advantage of treating them in that particular line rather than as seronegative exclusively?
No, that's what I mean. My answer continues. If it is seropositive, that means your antibodies is B cell mediated immunity. If it is seronegative, you have two things. One, you haven't antibody is there, we haven't discovered. Second, antibody is there, it is restricted to the brain. Third, probably ours is not a B cell mediated immunity, so it's a T cell mediated immunity. So in T cell mediated immunity, till now, the only way of diagnosing is, one is by doing a brain biopsy. Second thing is indirect clue is you have a brain atrophy. So, and some people say, I mean, certain methods they are telling, but still the T cell mediated immunity, autoimmunity is not yet. I mean, we don't have any markers still now. Only way is just by clinically how we are treating it. Still, sometimes you are confused. I think the only absolute way is doing a brain biopsy.
Okay.
We with the more and the more we learn, we realize the more and more it is complex, and less we know about the detailing about all that information. So I think we had a wonderful 1 hour discussion. First of all, thank you, Madhav, in coming as a rescue, and as usual,
Pleasure is mine.
to the presentations to any. It is always a learning experience sharing those cases with you. And thank you, Subhaya sir and Urvi ma'am, in bringing those experiences and discussions. And also a special appearance by Dr. Durgesh, who actually added so many things. The whole reason why we brought this topic is it is clinically a challenge. You have a patient like this where you level them autoimmune encephalitis and your panel comes negative, you always has that suspicion in mind ki, are we doing a right thing or not. This is the reason the whole topic was brought, to say that 50% of a patient can have a seronegative or antibody negative. We may have antibodies, but we don't have a mechanism to detect them. One, some of them can also may be confined to a local brain parenchyma itself. They are not secreted to the CSF or serum. The third, sir said, it can be still a T cell mediated where you have no way to actually detect antibody. it needs probably a biopsy or something else. So all these needs a high index of suspicion, a typical clinical syndrome and characteristic, and ruling out possibility of mimics to this autoimmune encephalitis. The commonest will be probably a viral encephalitis. There were many questions related to what is the relevance or a sensitivity, specificity of your biofire panels or a HSB PCR, so that you are very confidently saying they are negative. So I have ruled out a possibility of autoimmune infective etiology, and you are pulsing steroids, which can collaterally do a damage. So these are all clinical syndromes, as Dr. Subhash sir said. A couple of days of acyclovir, a standard therapy, ruling out all other possibilities, not responding, nor see younger age group if it's possibly there, and typical characteristic feature of limbic encephalitis, or what sir was talking about, basal ganglia, limbic system involvements, and maybe additional findings in PET-CT may give a clue. The newer therapies other than steroids and IVIG, so I was discussing about a younger individuals where probably a seronegative, he may consider to actually do a plasma exchange over a IVIG if somebody can tolerate it better. And the later therapies which we are talking about is rituximab has been a standard, and other two drugs like tocilizumab and anakinra into a limelight of this. So this is a spectrum of discussion we had today. I thank all the participants to being there. We had a more than 100 participants in this later evening. We reached to a couple of thousands to a 10,000 audience in a day or two. Thank you all for your participation and keeping these academic sessions lively and on and on. Thank you all for this participation.
Thank you,
Thank you.
sir.
Thank you, Dr. Kola, for
Thank you.
inviting me.
Thank you, sir.
Thank you, Dr. Venkat, and everybody. Thank you, ma'am. And
Thank you.
Dr.
Thank you,
Durgesh,
sir.
and
Thank you.
thank you, Dr. Madhav.
Thank you.
Thank you, sir. Thank you, everybody. Thank you.